Although prostate cancer is the most common solid organ malignancy affecting American men and the second leading cause of cancer-related death, most men do not need to be screened or even diagnosed with their cancer. In fact, some recent data suggests that 1,000 men need to be screened in order to save one life. Because of the controversy surrounding PSA-based prostate cancer screening, many groups have advocated against prostate cancer screening, including the American Association of Family Practice.
PSA can induce a lot of anxiety in the patients if it's elevated and the patient's not sure whether he has cancer or not. The biopsies are painful, expensive, and can result in side effects like bleeding and infection. And many times, the cancers we discover are not clinically meaningful. And so if a man got screened, was discovered with a cancer that wasn't meaningful, notwithstanding that, many times he was treated. But the good part of screening for prostate cancer is something we have to keep track of, and that is it significantly reduces a man's chance of dying of prostate cancer, probably by 30 to 50%, depending upon the cohort of men you're looking at.
We sought to save prostate cancer screening by defining high-risk populations of men who A, deserve to know that they're at high risk, and B, the right to be screened for their prostate cancers. The test is based on single nucleotide polymorphisms, or SNPs, and these are single base pair genetic changes that essentially distinguish me from you. So there are over 300 million of these SNPs throughout the human genome, and we've identified several dozens of these genetic changes which are associated with prostate cancer. We then test you for those different genetic changes, and we put it into an algorithm, and it spits out a score. And that score helps differentiate you from others in the population. So then we identify men who are at below average, average, and above average risk.
We can measure polygenomic risk score in a child or in an adult, and it's completely stable because these are just the inherited single nucleotide polymorphisms we get from our parents. One of the exciting things we can do is measure the score in people with a family history. And some of those sons will have below average risk, some of them will have above average risk, and we can actually adjust our screening behavior based on that risk.
Polygenomic risk scores can really improve how we screen for prostate cancer. Many urologists in the United States use a nomogram from the prostate cancer prevention trial, the PCPT nomogram. But if he or she were to add the information from the polygenomic risk score to that nomogram, he or she will do a better, more efficient job in finding prostate cancer in the men who harbor clinically significant disease than would have been possible had he or she just used the nomogram alone.
The reason that national guidelines recommend shared decision-making for men who are 55 to 70 years old for prostate cancer screening with PSA testing is because it's a really complicated decision both for doctors and for patients. Patients who are low risk of prostate cancer may have false positive PSA test results, and if they do, they may end up having unnecessary biopsies and aggressive treatment that they may not need. On the other side of the coin, we don't want to miss that young man who has aggressive prostate cancer. So that's why the prompt testing is so useful, because we can identify those higher risk individuals and not screen as many of the low risk individuals.
You know, the last 18 months have been really challenging, where telemedicine before this pandemic crisis had occurred was at a clip of about 2% in the country, and it quickly pivoted to a 90% use. We need tools for better screening for prostate cancer and really stratification of who that patient is. Kaiser Permanente is the largest healthcare system in this country in a prepaid model. Southern California covers 4.7 million lives. We do about 25,000 PSAs a month. We're standardizing the care to be able to really effectively diagnose and treat prostate cancer in a shared decision-making model that tells a high-risk patient, yes, you need to aggressively follow you along, and the low risk, who has much more choices as to where they go in this pathway. You actually have a lot of interesting research that can come into understanding the clinical utility of Prompt PGS.
Prompt PGS has saved many lives already by identifying high-risk men who then eventually got screened and treated for their disease in a timely fashion. Stratify Genomics will focus its efforts on different diseases outside of prostate cancer. But within prostate cancer, we're hoping to marry information, both clinical information, pathologic information, together with somatic genetic change, to come up with a more comprehensive picture of risk and outcome from prostate cancer.